Hello, and thank you for watching our presentation. My name is Anita Corbett, and together with my partner, Randall Tran, we would like to present our evaluation plan for the Keep Me Healthy program. This is a program that targets childhood obesity by engaging pediatric primary care providers. Our presentation will cover the problem, the program, our evaluation approach, how we will plan to communicate the results to the community, along with the cost, and finally, our lessons learned through the process of developing this plan. Before we discuss the program and the evaluation plan, let's talk about the problem it addresses. Obesity is a chronic health condition that has been steadily increasing in the United States for decades. Overweight and obesity are defined as abnormal or excessive fat accumulation that presents a risk to health. For children and teens, overweight is further defined as having a body mass index equal to or greater than the 85th percentile, but not above the 95th percentile. Obesity is defined as being equal to or greater than the 95th percentile. While adults, children, and teens use the BMI screening tool to identify the condition, children and teens include age and sex specificity as well. A child's body is changing throughout the developmental years, and it is critical to understand what is considered a normal weight based on his or her current age. Data points from the Centers for Disease Control and Prevention cite that just between the years 2015 and 2018, 19.3% of children aged 6 to 11 and 20.9% of children aged 12 to 19 were considered obese. This compares to the same age groups in the years 1988 to 1994, who registered at 11.3% and 10.5% respectively. This health concern is not limited to the youth as it continues into adulthood, increasing the risk of chronic health conditions such as high blood pressure, stroke, type 2 diabetes, and coronary heart disease. To bring this topic home, in Texas, 17.3% of youth ages 10 to 17 are considered obese, giving Texas the ranking of 12th among the 50 states in Washington, D.C. in this age range. The goal of proactive interventions at the youth level is key to reducing the health risks of future adults. This is where Keep Me Healthy program fits in. The Keep Me Healthy program is based on the Maine Youth Overweight Collaborative. This was a joint initiative of the Maine Harvard Prevention Research Center and the Maine chapter of the American Academy of Pediatrics. It is aimed at improving care and outcomes for the overweight and obese youth. It targets childhood obesity, but it is designed for pediatric primary care practices.
The Keep Me Healthy program is based on the chronic care model, which identifies the 6 essential elements of a healthcare system that encourage quality chronic disease care. These elements are the community, the health system, self-management support, delivery system design, decision support, and clinical information systems. The objective of this program is to provide guidance and education to pediatric providers so they may better access obesity among youth. It is intended to promote healthy dietary habits and increase physical activity. This is done through brief interventions, nutritional education, and goal setting with parents during the regular well visits. The program design is based on an 18-month intervention that includes 3 1.5-day training sessions. During these training sessions, teams learn to provide counseling to children and parents on the 5-2-1-0 rule. Training includes the development of practice and provider improvements for the management of obesity following the chronic care model. The Keep Me Healthy program has a total of 22 tools and resources for use by clinicians to aid them in counseling children and parents about behavioral goals related to nutrition, physical activity, and screen time. Community is a central element of the chronic care model. As such, the evaluation approach taken for the Keep Me Healthy program intervention will be participatory model. This approach relies on the involvement of the stakeholder throughout the process and aids in building the capacity of those participating organizations for continued self-efficacy. There will be 12 participating self-identified sites and 9 non-participating control sites that will receive the same parent and staff surveys as those participating in the program. In order to achieve maximum impact on the participating facilities, teams will be comprised of 3 persons from each facility. Each team will include 1 physician, 1 secondary clinician, and 1 leading staff member. Training sessions will focus on how to implement the chronic care model. Team members will jointly make decisions regarding the program, such as patient assessment and tracking. They will be required to report to senior leadership staff. Additionally, they will put quality improvement protocol in place at a practice level to identify performance gaps in obesity management. They are encouraged to form alliances with state and community agencies to support the healthy lifestyle treatment plans recommended to their pediatric patients and families. After training, coaching and ongoing support are provided through bi-monthly conference calls and site visits. Emails will be sent to participating sites to provide the latest information, and performance feedback is provided by review of bi-monthly team reports. A final findings report will be sent to all stakeholders at the end. Our proposed budget for the 18-month evaluation is just under $65,000. Our evaluation design allows collecting data by using low-intensity, low-cost collection methods. And outside data analysis will be brought on board, assessing the results using SAS data analysis tools. The 5210 daily plan has been adopted in numerous cities and counties across this country since it's been created. Literature reviews of studies on the results indicate it has been successful at reducing the BMI of children and improve health outcomes. The success, however, is short run because the early intervention with families and pediatric clinicians is not yet widely practiced. Finally, the success of any implementation of a program of this nature requires the ability of all communities to access it.